Hey there everyone, welcome back for another week of Anatomy 201. This week we're going to be going over the axial skeleton, which encompasses our vertebrae, our ribs, our sternum, our hyoid. We'll be actually spending an entire lab looking at the skull because of its complexity. Now you might be saying, why is there a turtle, a giraffe, and a moose on my screen if we're talking about the axial skeleton? Well, you will soon see. Now, remember last week we talked about the two divisions between our skeleton. Here you can see in yellow, we have our axial skeleton, so the skull or vertebrae, sternum, ribs, sacrum, and hyoid. And in the gray, we have our appendicular skeleton. So we have our pectoral girdle up here and our upper extremities. We have our pelvic girdle and our lower extremities here. And we'll be looking at those in the next couple of weeks. Now, first to talk about some general features of our vertebral column. So we're going to be looking at this entire thing here and identifying some features. So there are 33 vertebrae in total, and in between most of those vertebrae are intervertebral discs, which you can see really good view from an anterior perspective, which are going to offer cushioning and some movement in there. This is fibrocartilage. You'll learn about this in your articulations lab. If you haven't started that yet, please make sure you start carving out some time for that. Now there's 5 vertebral groups. You can see up here in purple, we have 7 cervical vertebrae. In the thoracic region, we have 12 thoracic vertebrae. We have 5 lumbar vertebrae, 5 sacral vertebrae that end up becoming fused as we get older, and the same is true of the coccyx or the coccygeal vertebrae, but here we have 4 that fuse as we get older. So a good way to remember this is that you wake up and you eat your breakfast at 7 in the morning, right? You're getting up early, you're ready to get the day going, you're studying for anatomy lab. And then in the afternoon, around noon, you're going to have a sandwich or you're going to eat some lunch. In the evening, you might eat at about 5 o'clock if you're into the early bird specials. And then you'll top it off with 5 scoops of ice cream after your dinner. And then, of course, another 4 hours of studying anatomy before you go to sleep. When we are newborns, we are born with this primary C-shaped curvature. So we have not started walking or crawling yet, and we call this our primary curvature. As we get older, we start to develop adult curvatures or secondary curvatures after birth. So as infants start crawling, they begin to lift their head, and we call this our secondary curvature, and we start to develop a curvature here in our cervical vertebrae. As we age a little bit older, we then start to walk upright, and we start to develop our lumbar curvature right here. So we end up with sort of an S-shaped vertebral column with these 4 curvatures. So we have this convex, concave, convex, and concave curvature to that spinal cord, which is going to offer stability for us and movement as we go through our lives. Now, there are some abnormal spinal curvatures we should look at, and these can result from disease, bad posture, paralysis, or some kind of birth defect. You've probably been tested for scoliosis, and this comes generally from a lack of the proper development of a cervical vertebrae. And so as one of those vertebrae is sort of misaligned, it can throw our curvatures off laterally. And so you can see in this image, one of the shoulders is elevated and one is depressed. So there might need, depending on how severe that is, maybe a back brace or maybe just some physical therapy. Kyphosis is generally from osteoporosis, and this happens in elderly folks. The bodies of these vertebrae start to break down, and the they get sort of a hunchback in their thoracic vertebra. And then we have lordosis, which is in our lumbar vertebrae. This happens with really weak abdominal muscles, or it can happen during pregnancy. If we look at the general structure of a vertebra, we can see this really large body right down here. And again, just to clarify, we are looking at a vertebra, a general one, from a superior view looking down. And then what we also see here is this vertebral foramen. And when you stack all of our vertebrae on top of each other, each vertebral foramen in each of those vertebrae forms the vertebral canal, and this is what surrounds our spinal cord and offers a nice bony protection around that spinal cord. You can see the neural arch coming off of that body, and so we have a pedicle here and a pedicle here, and then we have a lamina and a lamina here. So this makes up our neural arch. And then we have different processes. Processes are bony projections that are coming off of this bone here. So posteriorly, we can see the spinous process. The body is anterior. And then laterally, we see our transverse processes over here and over here. Now, you don't really see the three-dimensionality here, but this is a process that is pointing superiorly. Down here, you can see this little nub of bone. This would be a process pointing inferiorly. So this is our superior articular process. And on that superior articular process is a piece of articular cartilage, which we call the articular facet. So you can think of facet as face. And so this is going to articulate with another facet that is residing on a bony process. Looking a little bit closer, we can see a couple of examples here on how these vertebrae articulate. Here we can see L3 and L4 inferior to L3. Now what we're looking at is we can see this inferior articular process of L3. So we were saying on our last image that inferior articular process is pointing inferiorly. It's also located inferiorly on this bone. If we look up here, we can see that transverse process sticking out laterally. We have our spinous process right down that mid-sagittal view of that vertebra. Now, this inferior articular process also has an articular facet. We just don't see it, and it would be on the other side of this, or anteriorly. The superior articular process of L4 also has a facet covered in hyaline cartilage that is facing you, but it's connected to this facet on this articular process. So this is a little joint right in here that offers a little bit of mobility, not a lot, so don't think of this as like your arm, but this is going to offer a little bit of movement. If we look from this laterally, again, what we can see here is that we've got our superior articular process, and down here we've got this inferior articular process. Now we have an inferior vertebral notch. So if this L1 vertebra was separated, we would just see a half circle. But when these two, L1 and L2 vertebrae, are articulated, we see that the inferior notch of L1 and the superior notch of L2 form what's called our intervertebral foramen, or the hole. A foramen is a hole in bone, a hole that is between, inter is between the vertebra. So the intervertebral foramen, and this is where our spinal nerves will come out and off of our spinal cord. Looking a little bit closer, then we can see here that intervertebral foramina, and we can see a closer view of those intervertebral discs. So again, the intervertebral foramina is formed from those notches, and this is what's going to allow for those spinal nerves to pass through. The intervertebral discs, they're going to bind the bodies of the vertebrae together, and they're going to absorb shock. They're made up of fibrocartilage, so they're going to form really strong joints. They do have a little bit of movement, and so if you think about 33 vertebrae, each with a disc in between them. Some of you may have herniated discs. I just wanted to show a couple of examples of what that might look like. So here we can see a normal spinal nerve coming out of that intervertebral foramen. Here's a normal disc. If we look at from a superior view, we can see this normal disc. But what happens is those discs can herniate and they can rupture, and some of that tissue can rip and tear, and this bulge then pinches our spinal nerve, which is what makes it really, really painful. Here's again, you can see another example of what a normal disc would look like, a degenerative, a bulging, a herniated, or thinning discs. So there can be a lot of different variations based off of what your body looks like. Now you might be interested in knowing that this is actually an image of my vertebrae, and so we can see a nice bulge right in here, so that's super fun. We have a little bit of a bulge kind of poking out here and a little bit bigger one here, so you know, it is important to take care of your bodies. I definitely thought I was invincible until I had this and was spending weeks in physical therapy. So not a ton of fun. And that was also after a couple of days laid out on the floor because I couldn't actually stand up and walk around. So I would definitely recommend bend at the knees and take care of your back. What we're going to be doing moving forward is we're going to look at each of these different types of vertebra, and we're going to be identifying different features that you'll find on each of these vertebrae. So one of the test questions that you'll be expected to know is to look at a vertebra and tell us what are the characteristics that helped you identify that vertebra as being a cervical, a thoracic, or a lumbar. So pay close attention to these features, make a list of features that are usable so that you can get those questions right on your test. All right, now cervical vertebrae have 3 foramina. So you can see these 2 that are lateral to the body, and we see this one that is more posterior. We've already talked about this one and what that one does. So we also then see our transverse processes sticking out here, and so they look a little bit different than the transverse processes that we just looked at a couple of slides ago. But in that transverse process is the transverse foramen, and foramina is plural, so we have the transverse foramina and we have that vertebral foramen back here. Now these transverse foramina allow for the protection of vertebral arteries and veins that are traveling up to your head and down, bringing blood back down towards your inferior vena cava. One of the other features you'll notice is on the spinous process, you'll see that it is bifid or forked. So this is a really good indicator of a cervical vertebra. And our last one, this is not really a feature, it's just kind of a cool thing to check out. But if you take your hand and you put it on the back of your head, and then you run your hand down over your neck, you can feel the spinous processes sticking out a little bit. But then as you get down to where your neck is turning into your back, you can feel a really sharp projection sticking out. And this is your C7, your vertebra or vertebra prominens. So, your body is full of these little indicators that physical therapists or physicians will use to try to identify where the pain is coming or try to figure out where they need to be listening in your body. The other thing to note is that our superior articular process and facet is facing superiorly, and the inferior articular process and facet is pointing inferiorly. Okay, so those are some features that you're going to want to make sure you're paying attention to. Any ideas who this beefcake is here, holding up the entire planet? If you're familiar with mythology, you probably said Atlas. So we're going to talk about the atlas and the axis. Now these are C1 and C2, our first and second cervical vertebrae, and they have specific names. Atlas, C1, is what is holding up our skull, which is why it gets the name Atlas, because our head is like the earth. It has these concave articular facets on the processes here, and we'll see that our occipital condyles will articulate here in these articulating facets. And so what this allows our heads to do is to nod yes. Okay, so if you are sitting at home right now and you're nodding up and down saying, yes, I will study a lot for my upcoming anatomy test. That is because of your atlas. Down here at the bottom is our axis. So this is C2. We see a structure right here called the dens, also called the odontoid process. And this fits inside here of this vertebral foramen of the atlas, and this is called the anterior tubercle. And so the dens will sit right in here, just posterior to this tubercle. And it's held in place by some ligaments, and it allows for the inferior articular process of the atlas to slide over these superior articular facets found on the dens, and it rotates around the dens and the odontoid process. And this allows us to shake our heads no. So if you are sitting at home and I said, do you think of anything else except for anatomy and physiology, you should now shake your head no, and you are using your axis. A closer look at how this works, we can see our atlas up on top, so our occipital condyles would be sitting right in here. Here's that dens of the C2 of our axis, and this ligament here is holding the atlas onto our axis, and that's going to allow for that left and right motion. Some features that you'll need to know on the atlas, I already mentioned one, our anterior tubercle. We can see our anterior arch right over here. Here's that superior articular facet, the transverse foramen that's indicative of cervical vertebrae, posterior arch back here, and the posterior tubercle. We don't have a body in this vertebra, so we have these lateral masses on both sides here. And then, of course, that really large vertebral foramen where our spinal cord is going to be running down there. Now, we have our friendly turtle here, and some would say that this atlas looks somewhat like a turtle's face. I'm not sure if you can see it. I sure do. The axis, some structures on the axis then to know about. We just mentioned the dens. Again, the articulating facets, transverse foramen and process. And then we've got our inferior articular process that you can see. And we do now see that lamina and the pedicle, and we do see a body that exists for the axis. And there's that bifid spinous process back here. Moving on into thoracic vertebrae. So here's that superior view and a lateral view. Some characteristics that we should look at and understand. No transverse foramen. That's great. You'll also notice once we get there is that lumbar vertebrae also do not have transverse foramina. So if you were on a test and you saw this and you said, oh, it's totally a thoracic, it doesn't have foramen, that's one characteristic. That is not a unique characteristic of this because lumbar vertebrae share it. So you're going to want to be looking for other characteristics that are unique and that tell you that this is a thoracic vertebra. Now, you could say that the body of this vertebra is larger than cervical but smaller than lumbar. So again, this is a relative term. If you say the thoracic vertebra is medium-sized, we don't really know what that means. If you say the body is small or large, again, it's a relative term. It's like superior, inferior, proximal, distal. You've got to use another structure in relation to that. The spinous process is pointing downwards and is angled down here, much more than what we saw with that cervical vertebra. And our superior articular facets are facing posteriorly now, so that's a little bit different. And then down here we can see that we have our inferior articular facets that are facing anteriorly. Okay, so a little bit of a change, and what that does is allow for more of a twisting motion in our thoracic vertebra. Now, what we also will see here is that we have costal facets, and I'm going to draw a circle around this with my laser. Costal facets. This is something that's going to start causing some confusion. So our superior articular process and facet, our inferior articular process and facet, but then we have superior costal facet, inferior costal facet, and a transverse costal facet. Now the term costal means rib, and so here we're going to have a rib articulating. Down here, a rib is going to articulate, and right here, a rib will articulate. When we hear articular process and facet, you should be thinking that a vertebra is going to articulate at that point. Let's look a little bit closer. But first, let's see here. Here's our neck of our giraffe. Here's that really nice downward pointing spinous process. We can see the giraffe's ear, his horns, his eyes, his nose. Oh, that's a happy giraffe with the cloud in the background. All right, now our lumbar vertebrae. Again, here's our superior view. Here's our lateral view. What we see is, again, no transverse foramen, no costal facets. We do see a really thick body, much bigger than the others. It's real blunt. It's got to carry a lot of weight down in our lumbar vertebrae. It really bears a lot of the forces. So our spinous process, though, is a little bit different. It's not bifid and it's not pointing inferiorly, but it's much more square and straight. So that's a good characteristic. Now, the superior articular process and facet, you'll notice, face medially. And the inferior articular process and facet is going to face laterally. And what that does is when you put in when you articulate here, that is going to resist twisting movements in the lumbar vertebrae. Your intervertebral discs are at their weakest point when you bear load and you're twisting at the same time. So this is if you've ever moved furniture or you've ever worked in a warehouse where you're carrying a lot of weight. They say bend your knees, keep your back straight, and stand up and hold that weight and then twist and move, because if you are twisting, that's when you can tear a disc or herniate a disc. And here's our friendly moose coming to take a peek at our lumbar vertebra. We can see his nose, we can see his little beard here, his ear, and his antlers up here. And so, hi Moose, thanks for helping us out. Get a nice little comparison. Now again, you cannot use that this vertebra looks like a moose on a test. No animal references, that will not get you points. I would recommend printing out this slide. Using this as a really good study technique to compare and contrast our cervical, thoracic, and lumbar vertebrae. You can see all the distinctions between each of these. Again, please practice this for your upcoming tests. It will help you be more successful. Moving down, We are now at our sacrum, and so we're looking at an anterior view here. There are 5 separate sacral vertebrae that fully fuse by the time we're age 26. So we could see S1, S2, S3, S4, and S5 right down here. This sacrum is for support. It has a wedge shape, and if you take a second to think about why it's wedge shaped, I bet you know the answer. What did you say? Wedges are really strong. Our pelvic girdle is going to sit on the edges right here, and it's going to articulate. And as you put weight on your vertebral column, it pushes down on the sacrum, and it forces that wedge-shaped sacrum into the pelvic girdle, and that's going to help hold that vertebral column up and support and put weight on that pelvic girdle. Our ala then means wing, so this is the part that's going to articulate with our ilium and on our pelvic girdle. Now down here, the coccyx may actually be fused to the sacrum. Generally after multiple births in a female, that coccyx will end up fusing. But in males, it tends to not be fused to that sacrum. Now, it's hard to determine on a PowerPoint because you kind of lose that 3-dimensional view, but this is why it's really important to go into labs and open labs, is this anterior surface actually is a little bit curved, it's concave, and it's smooth. Now, our sacral foramina over here, these are the anterior sacral foramina. These were intervertebral foramen, and this is where we'll see nerves and blood vessels protruding out. You can also see these 4 transverse lines here that indicated where the 2 vertebra bodies, the vertebral bodies, fused, where there used to be an intervertebral disc. Posteriorly, we see that our spinous processes have fused into this median sacral crest. The transverse processes have fused into the lateral sacral crests. We have our posterior sacral foramina here, here, here. And then we have our sacral canal that ends as that sacral hiatus. What you'll notice though in labs is that this is not present on our plastic bones, so do check out some of the real bones if you can, just to kind of get a better feel for that sacral hiatus there. And then last over here we have this auricular surface. This auricular surface is what's going to form that sacroiliac joint with our pelvic girdle. And last but not least is our coccyx. Our coccyx, remember, are 4 small vertebrae. They end up fusing by the age of 30. They are an attachment site for muscles, and they have these little horn-like projections coming off of coccygeal vertebra of 1 called cornu, or cornua for plural. And this is where ligaments will attach that up to our sacrum. Now, back up towards our skull, we have one bone called the hyoid bone. The hyoid bone is helps in swallowing and the movement of your tongue. When we get into muscles of the head and the neck, you're going to see that there's a bunch of muscles that attach to the hyoid and help with swallowing. They help with chewing and communication. This is the only non-bony attachment bone in our bodies. It's suspended by different muscles and ligaments. It doesn't actually articulate with another bone. So that's kind of cool. All right, so moving into our ribs and our thoracic cage here. We're making the long push here. We're almost done, but we do want to address these parts of our axial skeleton. Now, the thoracic cage consists of our thoracic vertebra, which you can't really see here. You can see a couple posteriorly, our sternum, and our ribs. So these are going to offer a lot of protection for our heart and our lungs, and they're also going to act as an attachment site for that pectoral girdle, our clavicle and our scapula, as well as some limb muscles that will act on our arms. I mentioned they're going to protect our organs, and what we'll see as you get into our muscle chapters is that this thoracic cage can be expanded by respiratory muscles. So we'll have muscles that can connect between each of these ribs, and we'll also have our diaphragm down here inferiorly. And this is going to help expand those ribs and increase the amount of air that we can bring into our lungs. We have true ribs and we have false ribs. True ribs are attached to the sternum with hyaline cartilage, and so they are going to articulate in the back with our vertebrae. They're going to curve around, and then they're going to articulate to our sternum with this cartilage or costal cartilage, which is a hyaline cartilage. These connections go directly from the rib to the sternum, and so this cartilage belongs to rib 1. False ribs, then, if you look down here, are ribs 8 through 12. 11 and 12 are actually floating ribs and don't even articulate. So you can see 12 here, you can see 11 is coming down here. So those are our floating ribs. Our 8, 9, and 10, you can see their cartilage comes up and actually connects to the cartilage of rib 7. So rib 7 is a true rib because the cartilage coming off of rib 7 connects to our sternum, where 8, 9, and 10, the cartilage coming off of those ribs actually attaches to the cartilage in rib 7, and we have a little bit of a supportive cartilage right here with 6. So there's 12 ribs, pairs of ribs in both sexes. To look a little bit closer at a rib, we have some structures that you'll need to identify. So we have our head of our rib, the neck, and the tubercle. And this tubercle is going to be a really important feature for you to know. Now, down here in the inferior portion of this rib is what's called the costal groove. This is going to be a lot easier for you to identify in lab. You'll be able to feel it. This inferior portion of the rib is almost like a knife shaped. It's a little bit, it comes to like a finer point on the bottom than the superior aspect of this rib. It's a little more rounded. So the head and the tubercle are, again, connected by that neck. And we talked about the costal groove. You'll see some small nerves and blood vessels that run through there. Now, looking inferiorly here at this image, we can see that the tubercle is going to articulate with the transverse process of a thoracic vertebra. And the head is going to articulate with the body of a vertebra. But of course, this is where it gets somewhat complex. And so you'll want to practice this at home and in labs. So let's start here with our T5 and T6 vertebrae that are articulating here with our intervertebral disc. So now what we can see is we have rib 6, and rib 6 is actually connected between T5 and T6. So here is our superior articular facet on rib 6. Now remember what I said about articular. You should be thinking a vertebra is going to connect at that facet. So if we are talking about, if you were to cover up, put your hand over the screen and cover up T5 and I pointed right here and I said, this is superior articular facet. And I said, what would be behind my hand? And then I lifted my hand, you would say, oh, it's a vertebra. Perfect. I knew that because it's an articular facet. Now looking at T5, if we look here, we can say this is our inferior costal facet. Now put your hand up to your screen and cover up the rib and what's going to articulate at the costal facet. And now pull your hand away. Oh, it's a rib. Costal for ribs. So this is going to be where we see a rib attaching. So the superior articular facet of rib 6 connects or articulates with the inferior costal facet of this vertebra of T5. The inferior articular facet of rib 6 joins with and articulates with the superior costal facet of T6. So this gets really messy with all this terminology. Now looking superiorly, we can see again that our transverse costal facet for rib 6 here is actually joining to T6. So this is where it gets its T6 or rib 6 name. Here's a review of some of those rib features. Please be sure to use this to help you identify a rib in lab. One of the questions that you will have to answer on a test is how to identify a left versus a right rib. And so on a test, your TA will leave out a bone and we'll say, here you go, which side is this rib from? And you'll have to use the tubercle, which should be pointing inferiorly, the head of the rib, which should be pointing posteriorly, and the costal groove will also be pointing inferiorly. And that should kind of help you identify whether or not this is a right or a left rib. Last, we have our sternum. The sternum is composed of 3 fused bones. So the first is our manubrium, right up here. Our second is the body of our sternum. And our third is the xiphoid process, and you can palpate that on your own sternum. This can be easily fractured if it gets hit or you get an impact or you get in an accident. Sometimes even during CPR, this xiphoid process can break or even rupture or puncture the liver. So you have to be careful with that if you're doing CPR on someone. Key features, other key features that we should notice or take note of that you're going to want to find is your clavicular notch. This is where our clavicles articulate with that manubrium. Our suprasternal notch, you can feel this on yourself. If you follow your collarbones or your clavicles, you'll feel the really large ends right over here. And then if you kind of go in between those, you'll feel that sternal notch. And then if you come down about 2 fingers from that sternal notch, you should be able to feel a little bit of a ridge right here, the sternal angle. And then along the sternum here, we can see these costal notches, and this is where that costal cartilage is going to articulate and hold those ribs in place. Well, that is it, ladies and gentlemen, for our Lab 3 Axial Skeleton lecture. Good luck. Have a wonderful rest of your day.